Welcome, everyone, to our third installment in our Pediatric Hospital Medicine podcast series. Let's do our disclaimer. This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. So, I am Dr. Tony Tarchichi, your host. Just to remind you, we're coming from Children's Hospital of Pittsburgh of UPMC. I'm a part of the Paul C. Gaffney Diagnostic Referral Group, which is our hospitalist group. I'm M.P.H trained, in case anybody wanted to know. Now, I'm going to introduce our guest, and then we're going to talk a little bit about what we're going to do today. So my guest today is Dr. Nader Shaikh. He is an associate professor in the Department of Pediatrics with the General Academic Pediatric Group. He has authored numerous articles, and some of which we're going to talk about today, so I couldn't think of anybody better. Nader, thank you very much for joining us. I really appreciate you taking the time out of your schedule to be with us. Could you please give us any conflict of interest you may have?
Thanks, Tony. I really have no conflicts to disclose.
And I don't have any conflict of interest as well for this one. Now, for this podcast, I promised you we would do a UTI focus with a focus on UTI bacteremia. I also got a little ambitious, and I've decided to try to cover some of the AAP UTI guidelines and then really give a little bit of a deep dive on urinalysis as well. So now that we've talked about that, let's begin. So the first question people would ask is, why do this lecture? Why do this podcast specifically on UTI? What is so special about UTI specifically? To answer that, our first paper we're going to discuss is the changing epidemiology of serious bacterial infections in young infants. This was by Tara Greenhow et al., and this was in the Journal of Pediatric Infectious Diseases in 2014, so not long ago, volume 33. Now, this was a retrospective study from Kaiser Permanente, which went to the EMR and ID'd all the blood, urine, and CSF cultures that were obtained in full-term infants born between January 1st, 2005 and December 31st, 2011, who presented to care at any of the Kaiser Permanentes, and they had to be ages 7 to 90 days of age to participate in the study. Now, they excluded infants with any underlying medical conditions, any neuromuscular, cardiovascular, respiratory, GI, metabolic, hematologic, immunologic, other congenital or genetic malignant or renal anomalies, and they were also excluded. Cases that were taken were positive cultures, either in the outpatient, in the ER, or in the first 24 hours of hospitalization. This was a 7-year study, like we said. During that time, there was 224,553 full-term infants born at Kaiser Permanente. 6,780 infants had at least one blood, urine, or CSF culture during that time. 1,640 cultures from 548 infants were excluded because of the underlying medical conditions. So once you exclude duplicate cultures from the same source, that leaves us with 6,232 infants. So serious bacterial infection occurred in 13.5% of those patients, which is like 842. That's the whole number. So the 842 infants actually had 968 serious bacterial infections, including 129 bacteremias, 823 UTIs, and 16 bacterial meningitis. Now, two things struck me about that. One, how low meningitis was, which is only 16, which I thought would be higher, and how high UTIs were, 823. Now, 45 of the UTIs, to be fair, occurred after a previously ID'd serious bacterial infection, with 44 occurring after a preceding UTI. And among infants 70 to 90 days old with a first-time serious bacterial infection, this study showed that 92% had a UTI, which is huge. And interestingly, but not surprisingly, infants that were aged 7 to 28 days were more likely to get a complete evaluation, including blood, urine, and CSF. So this was the first study that I read, or this was one of the better ones that I read. There was a couple that were older, where it really showed in a huge population that UTI is the most common cause of serious bacterial infection. If you're asking what the most common pathogen causing bacteremia was in this study, it was E. coli by far. E. coli caused 78 bacteremias, 719 UTI, and 7 bacterial meningitis. And remember, we only had a total of 16 bacterial meningitis, so it was overwhelming. The next two most common ones were Klebsiella and then GBS in that order. So we talked about why I like the study. The incidence rate of serious bacterial infection is 3.75 in 1,000 full-term infants. But it occurred more frequently in those febrile or sick enough to have a culture obtained, and that number is 13.5%. So the next step, and I think, Nader, you'll appreciate this because some of your papers were based on this, is that I felt the next appropriate step, if we're going to review this, is to go through the guidelines. The AAP UTI Clinical Practice Guideline for the Diagnosis and Management of the Initial UTI in Febrile Infants and Children ages 2 to 24 months was published in September 2011 in Pediatrics, volume 128. Now, the way the guidelines are written, there's about 7 major bold points and then explanation of each of the points. What we're going to do, I'm going to go through the 7 bold points and go into a little detail on the minor points, on the explanations for the points, because it's related to some of the articles you've written. So the first one is obtain the urine specimen through cath or suprapubic aspiration. And I'm going to just say SPA for that to save me some time. The diagnosis of UTI should require both a UA that suggests infection and the presence of at least 50,000 colony-forming units per ml of a uropathogen cultured from a specimen obtained through cath or SPA. The duration of therapy should be 7 to 14 days. And interestingly, the guidelines under this one recommended for infants deemed too, quote, toxic, end quote, or unable to retain oral intake, they should get some parenteral antibiotic therapy until they exhibit clinical improvement, and they thought that would be within 1 or 2 days. Now, there's no evidence at that point to distinguish between treatment of 7 verse 10 verse 14, and the range is just allowable. The only thing they really talked about here that I wanted to bring up was nitrofurantoin. They recommended it not be used to treat febrile infants with UTIs because parenchymal and serum antimicrobial concentrations may not get high enough to treat pyelo or urosepsis because this agent is excreted in the urine. So the next major point is febrile infants with UTI should undergo renal and bladder ultrasonography. The purpose, of course, is going to be to detect anatomic abnormalities that require further eval, like more imaging or VCUG, or urology consultation. The timing of the renal bladder ultrasound depends on the clinical situation, and it's not standard. So they recommended if you're worried about serious complications such as renal or perirenal abscesses or pyelonephritis associated with obstructive uropathy, especially when the clinical illness is unusually severe or clinical improvement is not occurring, specifically substantial clinical improvement, they recommended an ultrasound during the first 2 days of treatment. For febrile infants with UTIs who demonstrate substantial clinical improvement, you don't have to image that early during the infection. And the reason is they saw in animal studies, E. coli endotoxin can produce dilation during the acute infection, which can be confused with hydronephrosis, pyelonephrosis, or obstruction. Also, it's common to have change in the size and shape of the kidney and the echogenicity of the renal parenchyma attributable to edema are also common during an infection. For these 2 reasons, it's inappropriate to consider a renal bladder ultrasound performed early during an acute infection to be a true baseline study for comparison for later. And we get into a little bit of numbers, which I did find interesting, so we're going to discuss briefly. For infants, febrile infants 12 to 24 months, a renal bladder ultrasound is going to yield abnormal results in about 15% of the cases. 1 to 2% of the cases will have real abnormalities that would lead to action, like VCUG, referral to surgery, urology. But 2 to 3% between that number will be false positive results, which will lead to unnecessary and invasive evaluations. Now, the guidelines felt that the benefits here outweighed the risk because the seriousness of these potentially correctable abnormalities in the 1 to 2%, coupled with the absence of physical harm of the actual test itself, it's an ultrasound, it's non-invasive, that was a tipping point. Now, that being said, like you all, I've had patients that have either have a track record of poor follow-up and you're just concerned that they may not come back to get an ultrasound on the outpatient side in a reasonable time period, or what we have here in Children's Hospital of Pittsburgh We have some patients that come from very far away, 2, 3, or 4 hours, and maybe where they live, the ultrasonographers or the radiologist are not comfortable doing one in a child this small. So while they're here, I will get an ultrasound, but I will do so knowing there is this risk of a false positive. So if the ultrasound is negative, then I will use that as a comfort for me. If it's positive, I'll know that there is a risk of this being a false positive, so then we'll probably consult urology, and we'll have to keep that in mind. The next major point the guideline talked about was VCUG should not be performed routinely after the first febrile UTI. It's indicated if the renal bladder ultrasound reveals hydronephrosis, scarring, or other findings that would suggest a high-grade VUR, obstructive uropathy, or any other atypical or complex issues. And if you get a recurrence of the UTI, then febrile UTI, you should consider a VCUG. After a UTI, the last point is, after UTI is confirmed, parents or guardians should be counseled to seek prompt medical evaluation within 48 hours for future febrile illnesses to ensure that recurrent infections can be detected and treated promptly. And Nader, this I think points to a paper you did on renal scarring and prompt medical delay of antibiotic therapy can actually increase the risk of renal scarring. And I think you and Dr. Hoberman, the number I believe was greater than 48 to 72 hours. If that was the delay, then your risk of renal scarring, I believe, doubled.
Yeah, actually the risk was sort of went up with time, so that we didn't find any threshold effect of the 48 hours, but it seemed like every hour that your risk went up by about 1%. So in 48 hours, it went up by about 50%. So that's when you double. Now, you have to understand the risk of scarring is really low to start with. So if you're 3% chance of scarring and you wait 48 hours, it might go up to 6. So it's going to still be low, but it's probably important not to, if we're not doing a VCUG anymore with the first UTI, the converse is true, that you have to catch the UTIs early and treat them if you want to stay out of trouble. So we think it's important to diagnose UTIs as soon as possible and get the children started on medication.
Now, the next, I want to kind of bridge this to talking about the urinalysis. One of the things the guidelines discussed, I want to go into, then we're going to go into another paper. They talked about, to ensuring the sensitivity and specificity of the UA, the specimen must either, 1, be 1 hour after voiding and maintaining it at room temperature, or less than 4 hours after voiding with refrigeration. And one of the things that we as hospitalists we always look at, when we look at a UA, is obviously the leukocyte esterase, the nitrite, and the white blood cells, looking for pyuria. Well, I guess everyone looks at those two, not just hospitalists. Let's start the nitrite test. We're going to discuss that for a second as from the guidelines. The conversion of dietary nitrate to nitrite by bacteria requires about 4 hours in the bladder. A nitrite is not a sensitive marker for children, particularly infants, because they empty their bladder frequently. Therefore, in infants, the nitrite test may have little value in ruling out UTI, and not all urinary pathogens reduce nitrate to nitrite. But the test itself is highly specific. It's 98% as per the guidelines. So when it's positive, it's helpful, but the sensitivity alone is about 53%. Now, going to the leukocyte esterase test, when used according to the guidelines, and we're going to get into this a little bit, in the context of a patient with clinically suspected UTI, its sensitivity is reported about 94%. Now, if you have a negative leukocyte esterase in a patient with bacteriuria, then that patient could have, according to the guidelines, asymptomatic bacteriuria versus a true UTI. And Nader, in this one, you quoted a paper from 1985 in Acta Pediatrica Scandinavica, Epidemiology of Bacteriuria During the First Year of Life, which talks about that asymptomatic bacteriuria in the first year of life is extremely low, less than 1%.
Mm-hmm. Yeah, this is a study that can only be done in Sweden. Basically, what they did is they enrolled children at birth, and they followed them longitudinally, and they put bags on the children. If the bag was positive, they did a catheterization or I think they did a suprapubic aspiration. And they found that some children who were asymptomatic had bacteriuria, but the number was low, and it was mostly in very young infants. And if you look at the details in that paper, you can see how often it happened. It's a very valuable paper.
Now, from here, the guidelines, I'm not crazy about how they're written, because from here they don't really have a section white blood cells or pyuria, but they just go into it. And they talk about how false positive tests are common for white blood cells in EUA, and numerous conditions other than UTI, including fever from such things as Kawasaki's or even vigorous exercise, can cause white blood cells to be in a UA. And they say it's rare not to have pyuria in a child with true UTI. Now we're going to get to that because that's a big point. But they talk about the standard method of assessing pyuria. In the past, been centrifugation of the urine and microscopic urinalysis with a threshold of 5 white blood cells per high power field. And if a counting chamber is used, then the finding of at least 10 white blood cells per microliter in uncentrifuged urine has been demonstrated to be more sensitive. But here, one of the things I do want to discuss, at Children's Hospital of Pittsburgh, we have something called an enhanced UA. And I was wondering, Nader, if you could talk about that a little.
Sure. This is one of the important contributions of Dr. Hoberman to the urinary tract infection field. Basically, if you put a drop of urine on a slide, the volume is not controlled, and that's what you're doing when you're counting per high power field. But what the counting chamber does is constrict the depth of the urine to 1 millimeter and squared in each direction, so that you can have a controlled volume, and then you count in the chamber, and there's squares where you count the number of cells, and that gives you a more precise estimate, and that's why this test has a higher sensitivity and specificity than the normal UA.
Thank you. Now, the AAP guidelines at this point begin discussing that they feel the absence of pyuria in children with a true UTI is rare, but they felt theoretically possible. And the reason they thought that is because their theory was the body's inflammatory response to a UTI would produce both the fever and the pyuria. So therefore, any child who's being evaluated because of fever should already have white blood cells in their urine. They also felt the explanation for significant bacteria in a culture in the absence of pyuria could really only include a contaminated specimen, insensitive criteria for pyuria, or asymptomatic bacteria, which they even quoted that it's often associated with school-aged and older females. And they did quote another study from the Journal of Pediatrics from 1983, which showed in infants 2 to 24 months old, only 0.7% of afebrile girls had 3 successive urine cultures with 10 to the 5th colony-forming units per ml of a single uropathogen. So those numbers are low too. Guidelines felt that the key distinguishing a true UTI from asymptomatic bacteria is the presence of pyuria. So that directly leads to my guest, because Nader, you were the first author on a paper in July 2016, Pediatrics, volume 138, number 1. You, Timothy Shope, Alejandro Hoberman, Alyssa Vigliotti, Marcia Kurzlasky, and Judith Martin, called The Association Between Uropathogen and Pyuria. Now, I'm going to talk about it, but feel free to interrupt. This was a study which sought to determine factors associated with the absence of pyuria in a symptomatic child whose urine culture was positive for a known uropathogen. So right away, kind of going against the guidelines in general, looking for where that's wrong. And all the data was received on children in the emergency department of Children's Hospital Pittsburgh, UPMC, between 2007 and 2013. It included kids less than 18 years of age with symptoms consistent with the diagnosis of UTI. Now, when I looked at the supplemental index in terms of the symptoms, it was a long list of symptoms that you guys felt should be included for a UTI. So abdominal pain, obviously dysuria, obviously frequency, urgency, but things like febrile seizure, things like constipation. Could you talk about why you use such a big array of symptoms?
Those were not the symptoms. Those were what the coders used to code the children's charts. So we wanted to catch all the patients who had a UTI. So we said we'll include various diagnoses that the children could have been given. And a lot of them had a fever, abdominal pain, we included them, and then we used strict criteria to define what a UTI would be.
Okay. And then, so children, then those children with a single UA and a single urine culture, each obtained within 3 hours of the other, were included. Bag specimens were excluded, and the kids with a positive urine culture were considered for the study. Those patients who were immunocompromised or on immunosuppressive meds were excluded from all analysis. And a positive urine culture in your study was defined as growth of a single uropathogen at a concentration of greater than or equal to 50,000 colony-forming units per ml from a cath specimen, or a single uropathogen at a concentration of greater than 100,000 colony-forming units per ml from a clean voided specimen. And pyuria was defined by the presence of a significant number of white blood cells on microscopic urinalysis greater than or equal to 5 per high-power field, or greater than or equal to 10 millimeters cubed. And a positive leukocyte esterase on urine dipstick was defined as 1+, 2+, or 3+. 0 or trace were considered negative. So the 1,394 children less than 18 years of age with symptoms that ended up in the study, with symptoms consistent with or a diagnosis consistent with UTI, paired UA, and a positive urine culture, 1,181 of those children met all inclusion criteria and had a microscopic UA assessing for pyuria. 694 of those kids got a cath to get the urine, and that's about 59%. Of the group, 89% were female, 80% were white. The median age was 23 months old, and pyuria was present in about 1,031, or 87% of the children, and absent in obviously 150, or 13%. And there was no difference you found between the children less than 2 months of age and the children greater than or equal to 2 months of age regarding the proportion of pyuria, or the proportion with pyuria, or the proportion with a positive leukocyte esterase test. The frequency of the isolated organisms you guys found were what everybody finds. E. coli is number 1 at 85%, Klebsiella 2 at 4%, Enterococcus species 3 at 3%, Proteus 4th at 3%, and then Enterobacter species 1%. Now, children whose urine culture yielded organisms other than E. coli, so not E. coli, they were significantly less likely to have pyuria or a positive leukocyte esterase. Both of these differences were statistically significant with a p-value less than 0.001 when compared to E. coli. And the results, first of all, especially UTIs caused by Klebsiella, Pseudomonas, and Enterococcus met those criteria by far. And the results were similar even when the analysis was restricted to those kids whose results were obtained by bladder catheterization. In your discussion, you discussed how another paper cited only 90% of children with UTI exhibiting pyuria, even when the urine specimen is collected by bladder catheterization. And then we talked about the article in 85, that the lack of asymptomatic bacteria in kids this age. And what I really liked was your study offered another explanation for the absence of pyuria.
Yeah, what we also, sort of similar to the guideline authors, believe that when you have a major infection, you should have pyuria. But we see kids in our clinic who look like they have a UTI, and we do the test and the leukocytes are negative. But 2 days later, the culture comes back positive. So we've been seeing those not frequently, but frequently enough to bother us. So we were wondering, rather than say there should be pyuria in every case, we said let's go find the cases which didn't have pyuria and try to see if we can explain some of them. And what we found was the type of bacteria actually determines to some extent the inflammatory response that you have in your bladder.
Yeah, so and the specific explanations I thought were fascinating. So one, so the bacteria that don't cause pyuria, maybe they have biofilms formed by some of the uropathogens that could affect the host's ability to mount an inflammatory response, or they could form intracellular bacterial communities, or something genetic or anatomic we just don't know about yet. And what I loved was you brought a thought process together which tied a few things together. First, if a non-E. coli organisms that can cause UTI with fever have lower odds of exhibiting pyuria with children with E. coli, and we know from other studies that absence of pyuria can lead to a delay in diagnosis and treatment of UTIs. And like we discussed earlier, we know that a delay in treatment of UTIs has been associated with a higher likelihood of renal scarring, then you can get a potential explanation, because in a recent meta-analysis you did in the JAMA Pediatrics in 2014, identification of children and adolescents at risk for renal scarring after a first UTI, a meta-analysis with individual patient data, it showed that children with UTIs caused by non-E. coli organisms were more likely to develop renal scarring. So it almost ties it all together. If these non-E. coli organisms are mounting less of an immune response, we're not seeing the pyuria, they're not being picked up fast enough, that could be leading to delayed treatment, which could lead to renal scarring. Did I get that right?
Yeah, I mean, that's one theory that we had, although there's probably multiple mechanisms, because E. coli seems to be very good at ascending, and maybe the other organisms are not so good at ascending. So there might be an interplay with the reflux, the type of organism, whether they have pili, how fast they're detected. So it's probably much more complicated than we understand currently.
So what this would tell me as a hospitalist is, if there's a febrile, especially a febrile infant, that I'm considering doing a urinalysis to rule out UTI. If I'm going to do that, I'm going to do a urine culture with it because of this risk. Am I interpreting that correctly?
Yeah, I mean, if you're going to the trouble of cathing a child who looks sick for UTI, I think it's probably wise to have a urine culture also ordered. I know when you get to older children who are clearly verbal and can express themselves, you could probably do things differently, but in a little baby who you're cathing, you sort of can't go back and cath them if you change your mind. So I would obtain a culture in all children who are sick enough to warrant a catheterization.
So now we're going to begin the bridge into our UTI with bacteremia part of the podcast. And I thought an appropriate bridge first would be to take a second, because this has been a lot of material all at once, and we'll do our mental break with bad dad jokes. I picked 4 that I thought were very good. So why did a scarecrow win an award? Because he was outstanding in his field. And the second one I'll do now is don't trust atoms, they make up everything. Let's move into this one. This next study was a diagnostic accuracy of the UA for UTI in infants less than 3 months of age. It is by Alan Schroeder et al. In Pediatrics, June 2015, volume 135. This was a nice bridge because it was a multi-center retrospective review analyzing infants less than 3 months old with bacteremic UTI. The central site was in Santa Clara Valley Medical Center in San Jose, California. They did it this way because they felt bacteremic UTI was a unique and it was a desirable condition to assess the sensitivity of the UA. This because the infection with the same organism in the blood and the urine makes either contamination or asymptomatic bacteriuria extremely unlikely. That minimizes the probability that the urine culture is a false positive. They got, and this is how hard this is to do, because they got 276 infants. This is from 20 hospitals at 11 hospital systems between 1998 and 2013, which is 15 years. The infants were included if they were less than 3 months old and had the same pathogenic organism isolated from the blood and urine. They were excluded if they had major comorbidities, which they defined, like most people define, as neuromuscular conditions like spina bifida, previous urologic surgery or other than circumcision, or immunodeficiency if they're managed in the ICU, or if they had an indwelling urinary or central venous catheter at the time of the cultures being drawn. They were the total of the 276 I told you with the bacteremic UTI. They did exclude 31. 12 had no UA and 19 had urine culture less than 50,000 colony-form units per ml, which left 245 infants with bacteremic UTI, and they compared them to 115 similarly aged infants with a negative urine culture. The only statistically significant difference between the characteristics of the two sets of infants is the percentage of those with documentation on how the method of urine was collected. There was more from the negative urine culture group had proper documentation on how the urine culture was collected. Otherwise, they were equivocal groups. Of the various individual UA components, comparing these two groups, leukocyte esterase had the highest sensitivity, 97.6%, and nitrite had the highest specificity, 100%. But once you categorize those with trace leukocyte esterase as negative, which they didn't at first, the sensitivity of leukocyte esterase dropped to 95.7%, and the specificity goes up. So there was only one infant in the bacteremic group with a complete UA that was entirely negative, but still had bacteremia. So when you compare the aggregate UA components, you still do well. So when you selected a positive UA, which included pyuria and or leukocyte esterase, the sensitivity was 99.5% and the specificity was 87.8%. They were both higher than those calculated by using the AAP definition of UA. So this was interesting in that it really increased the sensitivity of the UA. And if you're wondering, again, the most common organisms retrieved, which should not surprise you, E. coli was number 1, 91%, Enterobacter number 2 at 3.7, Klebsiella number 3, Enterococcus number 4, then GBS.
This was another interesting paper that we actually wrote a long commentary on the Yearbook of Pediatrics that just came out. There's been maybe 60, 70, or close to 100 papers showing that the sensitivity of pyuria for UTI is around 90%, even when the specimen is obtained by suprapubic catheterization. This is the first paper to show that it's close to 100%. So I personally concluded from this that it was an anomaly as far as the data went compared to all the other studies out there. And the population was the only thing that was very different, which was bacteremic neonates. So we sort of felt that it didn't provide enough evidence to make us, because the population was so highly selected, we sort of were unwilling to discount all the other literature on pyuria and believe that actually the dipstick is a perfect test for UTI. We just have a hard time believing that based on this one paper on highly selected children.
Has there been anything else you've seen like this after this?
This is the only study that has had such a high sensitivity for pyuria.
Okay. Now, following along the vein of bacteremic UTI, the next paper is febrile infants with UTI at very low risk for adverse events with bacteremia. This was by, and I hope I don't, I haven't done this yet, so if I mispronounce anyone's name in this, I apologize from now because it's likely going to happen, unfortunately. This is by David Schnadower et al., and this was in Pediatrics in 2010, volume 126. In this, they begin talking about UTI is the most common serious bacterial illness, which we've discussed. The paper was a 20-center retrospective review of infants aged 29 to 60 days with a temp greater than or equal to 38 and a culture-proven UTI. The inclusion criteria, UTI was defined by the growth of greater than or equal to 50,000 colony-forming units per ml of a single pathogen via cath specimen, or 1,000 colony-forming units per ml for urine culture obtained by suprapubic aspiration, versus between 10,000 and 50,000 colony-forming units per ml from a catheterized specimen in association with a positive UA. And they define positive UA by any organism visualized in the gram stain, trace or greater results for leukocyte esterase or nitrite on the ER dipstick or lab-based UA, and greater than 5 white blood cells per high-power field by standard microscopy. And they excluded transfer from other hospitals with previously obtained lab results, urine specimens obtained by techniques other than what we talked about, urine culture that grew multiple organisms, no measured temperature of greater than or equal to 38 degrees Celsius in the ED or at home within a 24-hour period of ED presentation. And the aim of the study, they wanted to determine the risk of adverse events and bacteremia in a large sample of febrile infants, ages 29 to 60 days with UTI, who come to the ED. And they wanted to come up with some sort of clinical prediction model for very low risk of adverse events and bacteremia for infants. And for outcomes, an adverse event was defined as, well, death was number 1, shock, bacterial meningitis, ICU or step-down ICU care or monitoring, ventilatory support, and they included BiPAP for that, need for surgical intervention, or other substantial clinical complication. And then they further defined each specific outcome in detail. What is death? What is shock? What is bacterial meningitis? That it's too cumbersome to go over, so I've given you the reference. You're welcome to go look at it. For the results, one of the center's data was completely excluded because of systematically missing the data. Initially, there were 2,477 potentially eligible patients, of whom 1,895 were included in the analysis. Most patients in the study had no significant past medical history, were febrile for less than 24 hours, and were well appearing. Again, E. coli was the predominant organism in the urine. Most patients were hospitalized and treated with parenteral antibiotics with a median length of hospitalization of 3 days. The adverse events occurred in 51 of the 1,842 patients. Adverse events were diagnosed immediately in the ED in about 26 of the 51 patients. Bacteremia was present in 123 of the 1,877 infants from whom blood cultures were obtained. The median time to positive blood culture was 16 hours. So again, under that 24-hour, greater than 95% of blood cultures are going to be positive time. 10 of the 123 patients with bacteremia had an adverse event, or that's 8.1%, whereas 41 of the 1,754 patients without bacteremia had an adverse event, or 2.3%. This study's main assertion is that infants with UTIs and fever who meet very low risk criteria for adverse events, i.e. those who are not clinically ill in the ED and have no high risk past medical history, could be managed less conservatively than commonly practiced. When they looked at the results of the patient characteristics from the H&P and the ED information, they created this low-risk criteria. For having bacteremia specifically, they felt low-risk criteria was not clinically ill in the ED, no high-risk past medical history, a peripheral band count less than 1,250 cells per microliter, and a peripheral ANC greater than 1,500 cells per microliter. The prediction model sensitivity was about 77.2%, and the negative predictive value was 96.8%. Bacteremia was present in 28 of the 862 patients who met all the low-risk criteria. None of these 28 low-risk infants had an adverse event. Now, they came to the conclusion by developing the prediction model we just talked about for patients at low risk for adverse events. Of the 1,206 patients in the very low-risk group, that's 65.5% of those analyzed, only one infant had an adverse event in their prediction model. This was a 46-day-old male, well-appearing, but the CSF studies were lost, so a subsequent LP 24 hours later after initial IV antibiotics revealed a negative gram stain, 34 white blood cells, 177 red blood cells, 54 milligrams of glucose, 85 of protein, and a negative bacterial culture. But because they lost the CSF, infectious disease wanted 21 days of IV antibiotics, so they counted it. So the reason I put this study in was A, to give you an idea of how many infants with a UTI will end up with a bacteremic UTI. There's not much on this particular topic. So again, just to quickly review the numbers, bacteremia was present in 123 of the 1,877 infants from whom blood cultures were obtained. So we're at roughly less than 10%. So we're going to do one more study from this part, and we're going to then talk a little bit with our guest. The one we're going to talk about now is bacteremic UTI management and outcomes in young infants. This is by Alan Schroeder et al. In the Archives of Diseased Children, I believe, 2015. There's a multi-center retrospective cohort study which set out to determine the predictors of IV antibiotic duration and association between parenteral treatment duration. It occurred in 11 hospitals across the U.S. The inclusion criteria was infants less than 3 months old had the same pathogenic organism isolated from the blood and urine, regardless of the urine culture colony count, UA, or even indication for the urine culture. Infants were excluded prior to data submission to the central site if they had major comorbidities, which they also defined as neuromuscular condition like spina bifida, prior urologic surgery other than circumcision or immunodeficiency, or if they were initially managed in the ICU, or if they had indwelling urinary or central venous catheters at the time the cultures were drawn. Infants were also excluded if they had received prolonged parenteral treatment for other reasons, like osteomyelitis or meningitis, or if data on parenteral treatment were missing, or if the transfer out of the study site occurred during the hospitalization. And they looked at length of stay in calendar days between admission and discharge, the duration of the parenteral antibiotics, the number of calendar days separating the first and the last parenteral dose. Relapses were defined as a second episode caused by the same pathogenic organism within 30 days of the initial episode, and readmission was defined as a rehospitalization for UTI and or bacteremia within 30 days. So the results. They initially had 276 infants that were identified with bacteremic UTI. Of that, 25 were excluded, 5 had missing data or were transferred out, 19 were treated for meningitis, so they were taken out. The most common organisms obtained were, again, E. coli, number one at 89 point. Every study has E. coli at about 90% of these patients. The mean standard duration of parenteral antibiotics was 7.8 days, plus or minus 4 days. And the mean length of stay was 7.4 days, plus or minus 4 days. Now, looking at figure 1, which is a podcast you can't do, but I'm going to describe it for you. It really drives this point home. There's a really wide distribution of the days of parenteral antibiotics. About 30 infants got 3 days. Less than 5 only got 1 day. 8 got 2 days. And 38 or so got 7 days. And the next big spike is 10 and 14 days. The clustering of days of the antibiotics in the study was not due to the included patient-level predictors. Basically, it was just 3, 7, 10, and 14, which are standard numbers used in medicine altogether. Of all the infants in this study, only 6, 2.4%, had relapsing UTI caused by the same organisms. 4 of these infants were readmitted to the hospital. No infant had relapsed bacteremic UTI. 4 infants had a recurrent UTI within 30 days caused by a different organism, the Enterococcus species. There was no difference in the duration of parenteral antibiotics between infants with and without relapsed UTI caused by the same organism. VCUGs in this study were more common in infants with a relapsed UTI caused by the same organism. Otherwise, there was no difference between infants with and without relapsed UTI caused by the same organisms. This suggested that relapsed UTIs are more related to an underlying genitourinary abnormality than insufficient treatment of the initial UTI. According to the study, there were 5 independent predictors of parenteral antibiotic duration. Increased age, year of the blood culture, and female gender were associated with a shorter duration, but these effects were small. It may seem a little odd that they chose to look at the relationship between parenteral antibiotics and relapsed UTI as opposed to relapsed bacteremic UTI, but that's because there was no cases of relapsed bacteremic UTI, so they felt they'd look at something else. And one thing we haven't said, which we should say, is there is no available published recommendations on the duration of parenteral treatment for bacteremic UTI, which is the initial reason for this podcast, is what does the literature say about the duration of parenteral treatment for UTI with bacteremia? And there's more on here. So the benefits of continued IV antibiotic administration with an infant who had recovered clinically was largely theoretical, the authors felt. In our last osteomyelitis podcast, there are risk with central lines, peripheral lines, being in the hospital like nosocomial infections, seasonal viruses, and of course hospital costs. So most clinicians got a second blood culture in this study to document clearance, and the article goes over that the overall yield of repeat blood cultures is low and the clinical parameters such as defervescence may be useful. And they also assert that the standard practice at all participating institutions was to provide a minimum of 7 to 10 days of total antibiotics, irrespective of the parenteral length. One of the things you may be thinking about is, can UTI with bacteremia increase the risk of some of the more significant side effects of UTI, like renal scarring? There was a study done by Dr. Hoberman et al. Back in 1999 in Pediatrics, oral versus initial IV therapy for UTI in young febrile children. In that study, they had 13 patients with bacteremic UTI, and none of them had evidence of renal scarring on a 6-month follow-up with DMSA scan, compared with 26 of the 288 other children with UTI and a negative blood culture. And in that study, children received either 0 or 3 days of IV antibiotics. So renal scarring is not as much of an issue as we thought it. We're not sure. We don't think it's as much of an issue. Nader, do you want to say anything about that?
This is a very difficult question because if you think 5% of febrile infants have a UTI and then 5% of those have bacteremia, this is a basically very, very difficult question to answer with data. So you will probably not see a study where they will tell you how to treat patients with bacteremic UTI because of how the numbers work out. It's just very rare. And to try to randomize them to 2 different arms is going to take 20 years. So I think you have to use some common sense and rely on the literature on non-UTI, just bacteremia in general. How's that done? all of these studies show pretty much that it doesn't seem to be very different if you have bacteremia as far as they can tell, but the power is so low that you really can't say much.
I'm going to break it up for a second with a couple more bad dad jokes, and we're going to finish with one or two more studies, and then we're going to wrap it up. So, why can't you hear a pterodactyl go to the bathroom? Because the P is silent. How many apples grow in a tree? All of them. Why can't you have a nose 12 inches long? Because then it would be a foot. I do enjoy those. All right. The next one we're going to go over quickly is diagnosis and management of bacteremic UTI in infants. This was by Heidi Roman, Pearl Chang, Al Schroeder, et al., also in Santa Clara, California, Santa Clara and Palo Alto, California. This was in Hospital Pediatrics in 2015, January. This study really set out to report the prevalence of bacteremia by age in a sample of infants less than 1 year old with UTIs to compare characteristics of infants with UTIs with and without bacteremia and describe treatment courses and 30-day outcomes in infants with UTI with and without bacteremia. This is what we were looking for. This is one of the more complex designs I've read for a study. So they used a retrospective cross-sectional design. So I tell you that because it's complicated to describe on a podcast. I'm going to do my best. So if you don't follow, I do apologize. To compare the clinical characteristics between infants with bacteremia versus non-bacteremic UTI, they used a retrospective double cohort design. In case you were like me and unsure what a double cohort study even was, they explained it. It's samples from 2 cohorts with varying levels of risk factors, in this case, presence or absence of bacteremia, and follows outcomes. This is different from a case control study, which samples are chosen based on the presence or absence of a particular outcome. This was all done at the Santa Clara Valley Medical Center in Northern California. The inclusion criteria were patients less than 1 year old who had UTIs between October 1998 and June 2012. 14 years. UTI was again defined the same as others, a culture containing a pathogenic organism with greater than or equal to 50,000 colony-forming units per ml by cath or 100,000 colony-forming units per ml by clean catch. And there was 2 cohorts, bacteremic UTI and UTI with negative blood culture. The bacteremic cohort was defined as growth from a blood culture obtained within 24 hours of the urine containing the same pathogen. So they have to be gotten within 24 hours of each other in the same bug. The exclusion criteria, NICU cases were excluded. Non-bacteremic UTIs contained infants with UTI and negative blood culture. They also decided to look at the duration of fever after treatment. This was calculated as time from the administration of the first antibiotic dose in the hospital until the last documented fever in the nursing notes. They looked at and recorded numerous characteristics with each infant, such as if the patient was ill-appearing based on their description, i.e. if the words lethargic, toxic, septic, or sick were used, the UA results, and more specifically, the white blood cells in the UA, how many days of parenteral antibiotics were given with a long course defined as, air quotes were long course, defined as greater than 7 days, and length of stay. Recurrent UTI or bacteremia was defined as a second episode of UTI or bacteremia within 30 days of the initial episode, and readmission was also defined as rehospitalization for UTI or bacteremia within 30 days of the initial episode. The results. They got a total of 1,379 cases of UTI. Blood cultures were obtained in 714 of those cases, which is 52%. The majority of UTIs were in boys, 55%. And blood cultures were more commonly ordered in boys with UTI than girls. Bacterial growth was documented in 101 blood cultures. Of that 101, 41 were considered to be contaminants. So that means 5.7% of all the blood cultures obtained were non-Staph aureus species of Strep viridans or Bacillus. There were 3 patients with blood culture specimens which were positive, but in whom the organism was not present in the urine. These organisms, bacteria, were Pseudomonas tutzeri, Neisseria meningitidis, and Candida species. That means that leaves us with 57 infants with bacteremia and UTI in the same pathogen. And this is what Nader was saying. This is over 14 years at a major medical center. This is not a big number. This number, though, represented 4.1% of all infants with UTI and 8% of infants with UTI in whom blood culture was obtained. The prevalence of bacteremia with UTI decreased with age, but was not significantly different between males and females. E. coli, again, was the most common organism, followed by Enterobacter, followed by Enterococcus, followed by others. Of those 57 infants with positive bacteremia and UTI, 2 were excluded because the charts weren't available. The other 55 were compared with 110 age and gender-matched infants with UTI and negative blood culture. CBC was obtained in all the bacteremic infants and all but one of the non-bacteremic infants. A majority of people had UAs. Of that analysis, they found that serum percentage, band count, and UA greater than 10 white blood cells per high power field and bacteria in the UA were increased in infants with bacteremic UTI. Otherwise, there was no difference between the 2 groups on presentation. Abnormal urinary imaging results subsequently were not different between the groups, but not all infants received urinary imaging, and it was significantly more common to have imaging in the bacteremic group. And according to the data, the likelihood of having a positive blood culture with UTI seems to decrease with age, highest in the 0 to 1 month group. And other observational studies done in Israel found the same thing. The highest percentage of patients who are going to get a bacteremic UTI are usually under that 3-month-old mark. There was a significant variation in duration of the parenteral antibiotic and hospital length of stay for infants with bacteremic UTI. The distribution of the length of stay for infants with bacteremic UTI was similar to the duration of parenteral antibiotics. So in the bacteremic UTI group, so the group with UTI and positive blood culture, same organism, infants who received parenteral antibiotic courses for more than 7 days were younger than those who received shorter courses. They were 60 days old versus 101 days old. But there was no other significant difference between these groups in terms of gender, comorbidities, initial lab parameters, initial clinical appearance, highest fever, time to effervescence, or subsequent imaging. Even when the youngest group of infants, less than 60 days old, the treatment, even within that group, the treatment varied. And how did it vary? It's a good question. It varied. The duration was less than 4 days in 7 of the 28, 5 to 7 days in 13 of the 28, and greater than 7 days in 8 of the 28. So within that group, there's a huge variation in how many days of parenteral antibiotics were there. So there's only 28 of those infants less than 60 days old. 7 of them got less than 4 days, 13 got 5 to 7 days, and 8 got more than 7 days. Whereas most, 80% of the bacteremic infants who were initially hospitalized, their fever durations were less than 24 hours after antibiotic administration. Not one of the infants required ICU transfer, vasopressors, or intubation. There was one infant who had ended up having a hip infection and having prolonged antibiotics for that. CSF was obtained in 28 of the 55 bacteremic infants, and only one infant had bacterial growth on CSF culture. That infant had E. coli, and they felt it was traumatic. It was a traumatic tap, and the growth they felt was actually due to the contamination with the blood from the traumatic tap. That being said, there are other papers which show UTI can lead to bacteremia, which in a very, very small group could lead to meningitis. None of the 55 bacteremic infants had a recurrent bacteremic UTI or a recurrent UTI with the same species within 30 days of the initial episode. So this is probably going to be the last paper we have time for, but to summarize it, the interesting findings in this study, they confirm previous other studies' findings that bacteremia is rare in older infants with UTI. Also, that the clinical presentation of infants with bacteremia does not substantially differ from those without bacteremia. So if you're one of the hospitalists that is consulted in the ED, that they may not look sicker, and they probably won't. There was a wide range of hospital length of stay and duration of parenteral antibiotics for bacteremic infants. Outcomes were generally excellent, with prompt effervescence, easy clearance of bacteria from the bloodstream, and no 30-day recurrences or rehospitalizations with the same organism within their medical center. One of the issues I have with this study is I wish they would have told us how long, what was their length of treatment total after the parenteral antibiotics were taken off, how much of the oral, how much did they treat with oral. So in terms of discharge purposes, that would be a little more helpful, but I think it was great because it highlighted what we've been talking about, which is A, bacteremic UTI is a rare occurrence. B, those infants, and it's going to be primarily infants that are going to have it. It does occur in older children, but it's much more rare. They'll look the same as other infants who you think may have a UTI. Their clinical characteristics won't be different. C, we really don't know how long to treat these infants for. The literature is mixed, and as you saw in 2 or 3 papers now, And none of the infants had bad outcomes. All of them did well. None of them recurred with even a UTI. So it would tell me that shorter duration is acceptable. But I don't know if the numbers are too small to make that conclusion. And I don't know if we'll ever have numbers big enough to really give a sizable enough study. Even if we tried to do like a Cochrane review of all the studies done, do you think that would be enough, Nader? Or do you think this number's too small?
I think they're small in general, and the problem is they weren't randomized, so it would be difficult to rely on that. I think we just have to go with the bacteremia literature in general would be probably wiser.
So, and other points to just review before we wrap up. E. coli was the predominant organism in everything we read, whether it was bacteremic UTI or UTI in general. We went over the papers that were done here by Dr. Nader, Shaikh, and Dr. Hoberman in terms of the urinalysis, in terms of looking at leukocyte esterase and the nitrite and the white blood cells. In terms there's a potential for some organisms not to cause white blood cells in the UA. And we talked about how now the most common cause by far of serious bacterial infection in infants is UTI. So I hope this podcast was helpful. I hope you enjoyed it. I do want to say thank you to all my listeners who are listening right now. I do appreciate it. Feel free to email me if there are topics you'd like me to review. If you didn't like the review, please feel free to tell me why. If you liked it, please feel free to tell me why. I do want to thank my guest, Dr. Nader Shaikh. I really appreciate you being here. Thank you again.
You're welcome.
I would like to send a couple of acknowledgments to Dr. Allison Ramito, who initially presented this topic at our DRG Journal Club, which got me thinking about it. And also to Dr. Megan Keene Tarchichi, who helps me with everything I do. And then I would like to remind everyone that you're on the site where you download the podcast. There should be a link in order to go get your free one category 1 CME credit by answering a few questions, and that's courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh, and thank you to my group for giving me the opportunity to do this. For our next podcast, I'm not set on a topic yet. I'm thinking of bronchiolitis or orbital cellulitis with looking at preseptal cellulitis. If you have a preference, please feel free to email me. Thank you.